Bon dia. My name is Hogne Sandvik. I am a Norwegian general practitioner and the first author of this paper that I will present to you. It was published last year in the British Journal of General Practice. The paper describes the effects of personal continuity in general practice. But before going into details, I will show you a brief summary, a video.
In August, the British Journal of General Practice published the largest ever study conducted into continuity of care. Researchers at the University of Bergen had analysed the health records of 4.5 million people, virtually the entire population of Norway, and looked at what patients derive from a long-standing relationship with their GP. After adjusting for various confounding factors, what they discovered was little short of astounding. Patients who'd had the same family doctor for many years were 30% less likely to use out-of-hours services, 30% less likely to be admitted to hospital as an emergency, and 25% less likely to die than people registered with their GP for under a year. The risk of needing emergency care or dying began to decrease once patients had been with the same doctor for as little as 2 years, and continued to fall steadily thereafter. This dose-response relationship, in which the more you have of something the more you benefit, strongly implies causality. Knowing and being known by your GP really is good for your health.
The present organization of Norwegian General Practice was established in 2001. It is called the Regular General Practitioner Scheme, the RGP scheme. It has become very popular and covers the entire population. The scheme is a list system financed by capitation and fee-for-service. Usually 3 to 6 GPs work together in small clinics, but they have individual personal lists. Today, the average list size is approximately 1,000. Our study was based on linking 4 national databases. All Norwegian citizens have a unique personal identification number, and this ID number is used in various official records and allows for linking these records on an individual level. Statistics Norway provided demographic data about all inhabitants. The RGP registry contains information about all GPs and their listed patients. All patient contacts with GPs and out-of-hour services are reported to a central database called Control and Payment of Reimbursement to Health Service Providers. Finally, the Norwegian Patient Registry contains information about all patient contacts with specialized healthcare, including hospital admissions. Okay, then I will explain in more detail how this study was conducted. Our idea was that the duration of the doctor-patient relationship, the personal continuity, was important. This was our explanatory variable in the analysis. We had 3 dependent variables, all of which were outcomes in the year 2018, namely use of out-of-hour services, acute hospitalizations, and mortality. You will realize that these are complex associations. There are many possible confounders that affect our outcomes. However, we were able to adjust our analysis by including covariates, adjustment variables, from the databases I just described. First, we included several patient-related covariates. Age and morbidity are important examples of such confounders that may determine use of out-of-hour services, hospitalization, and death. In addition, such variables may influence the duration of the GP-patient relationship and thus obscure its effect on the outcome. Gender, ethnicity, and education level are other variables that may influence health, the use of health services, and mortality. Centrality is a rural-urban variable. Finally, it is possible that healthy patients with few visits may have long continuity without the benefit of being well known by their GP. Therefore, we also included the frequency of visits to the GP as a covariate. Morbidity was defined by the Charleston score, which is based on 14 groups of ICD-10 codes used in specialist and hospital care. Any use of the relevant ICD-10 codes during the 3 preceding years, be it outpatient or inpatient, was recorded. It is also possible that doctor-related factors may influence the outcome. And therefore, we included their gender, age, and general practice specialization as covariates. The number of patients listed with the GP may affect accessibility, and the number of vacant list places may be taken as an indicator of the GP's popularity and competence. Both these variables were therefore included as covariates. Okay, now we had a lot of variables that were included in 3 multiple logistic regression analyses, one for each of the 3 outcomes. Thus, we analyzed the association between continuity and our outcomes, adjusted for all covariates. Approximately 4.5 million individuals were included in the analysis. First, we look at what happens with the use of out-of-hour services as continuity increases. The reference value is 1 year. That is, the duration of the doctor-patient relationship is 1 year or less. Odds ratio describes the probability of using out-of-hour service compared to the reference. Thus, an odds ratio of 0.87 means that the probability is reduced by 13%. As you can see, the odds ratio is gradually reduced as the duration increases. After 15 years, the probability is reduced by 30%. Here you can see a similar analysis of the probability of being hospitalized. After 15 years, the odds ratio is 0.72, which means the probability of being hospitalized is reduced by 28%. You may notice that the confidence intervals are very narrow. This tells us that the results are robust. And then we have mortality, the risk of dying. This is the ultimate hard endpoint in medical research. As you can see, the odds of dying is significantly reduced already when the doctor-patient relationship has lasted only 2 to 3 years. After that, the odds decreases gradually as continuity increases. After 15 years, the odds ratio is only 0.75. All three analyses are shown in this figure. You can see that there is a dose-response relationship between continuity and the three outcomes. As the duration of the doctor-patient relationship increases, the probability of the outcomes is reduced. This indicates that the relationship is causal and not just an association. The study has received widespread attention, especially in Spain and in England. This article in the Times was important for arousing interest in the Parliament. The following video is taken from a discussion between the former and the present Secretary of Health, Jeremy Hunt and Steve Barclay.
Could I recommend some scintillating summer reading for the Secretary of State, which is the study of 4.5 million patients that showed that people who see the same GP over a long period of time are 30% less likely to go to hospital and 25% less likely to die. Will he, after reading that, consider changing the GP contract to get rid of the micromanagement and replace it with what doctors and patients both want, which is to have a long-term relationship?
Well, firstly, Mr. Speaker, I think he knows me well enough to know that anything which is data-driven, that I will have a very close interest in reading.
Spanish doctors seem to have taken a special interest in the paper. I have noticed many hundred tweets, including this nice poster. Well, by this I end my presentation. I wish you good luck in developing and strengthening general practice in your healthcare system. Promoting personal continuity is important. Gracias por la vostra atención.